to understand how do you assess a geriatric patient. And the other one we're going to be doing is pain assessment. Both of those are two major skills that nursing staff need to be able to understand and to perform in the world that we live in now. So again, we're going to watch those together, and it will be recorded, so you'll be able to go back to it and review it. You also have the links to both of those scales, and you can always go to there, but I want to watch it together, and then I want to talk to you about each one of those scenarios or those assessments. So that's why we're going to do it together. Okay, so our skin health presentation with Anne-Marie, Emily, Stacy, Melissa, and Andrew. Are you ready? We are ready. Whenever you are.
Actually, we might be having some technical difficulties. I kept trying to pull it up on my computer because I told them I would share it, but my computer isn't letting me log on to Teams, so I had to do it from my iPad. And I think everyone else is on their iPad. Is there any way that we could send you the PowerPoint and you could scroll along with us and share it?
Yeah, we can. If you want to send that to me, send it to my email.
Okay, thank you.
Yeah, sure. You'll just have to tell me when to go forward, all right?
Okay.
All right. So let me get my email there. Oh, here it is. All right. All right. Do you think it's because you're using the iPad? Is everybody on iPads?
Yeah, I have my Mac computer, but every time I tried to log on this morning, it wouldn't let me like authenticate it. Like it just came up with like a blank screen no matter how many times I restarted it and everything. So I couldn't get on through my computer.
Okay. All right. Because I don't know.
Same. And I even restarted I deleted the Teams app from my Mac and everything, and it's still the same issue.
Okay. So maybe it may be some kind of technical thing with Teams. All right. Or iPads. But anyway, let me open up this PowerPoint. And then I'll share my screen with you. All right. All right, let me share. Is there any sound in it? Do you need me to cut the sound on?
I don't think so. I think you're okay. Thank you.
Okay, because sometimes I forget to hit the computer sound. All right, let's see. Share. Can y'all see that yet? Let's see. There you go. You should be able to see it now.
Yes.
Perfect. Oh, sorry. Okay. So all you have to do is just tell me to move it, and I will be happy to do it. So please go ahead. We're looking forward to this. I can't hear you, Melissa.
I always forget to do that.
That's okay. I do too. So
all right.
We're in this together. It's fine.
Thank you.
All right.
Our chapter was chapter 27, Skin Health. It's Anne-Marie, Emily, Stacy, myself, and Andrew. Next slide.
Oh, too far. Okay. Okay, so this chapter is all about skin health in the elderly. Before we go through this chapter, here are some of the terms to know. Epidermis is the outer layer of skin. Keratosis is small, light-colored, benign lesions on the epidermis. Melanocytes are epidermal cells that give skin its color. Mongolian spots are irregular, dark areas resembling bruises that may be found on the buttocks, lower back, and to a lesser extent on the arms, abdomen, and are more prevalent in persons of African, Asian, or Native American backgrounds. Photoaging, also known as solar elastosis, is skin changes resulting from exposure to ultraviolet rays. Pressure injuries are localized damage to the skin and or underlying soft tissue resulting from pressure or pressure combined with shear or friction. Pruritus, we all know what that is. It's itching. And turgor is elasticity. So who can tell me by looking at this picture what this person is suffering from? It's something from the list of terms to know. Anybody?
I know somebody's watching this picture. Come on, classmen, let's participate, please. It's important.
Mongolian spot?
Good job. So this is obviously not a, I'm not going to say normal spot, but like this is not a most common spot that you're going to find a Mongolian spot. So I thought this was a good example of a picture.
All right.
Next slide, please. Okay, so the easiest way to recognize when a person is aging are the changes involving their skin. What you do to your skin in your younger years will largely influence how your skin reacts and looks later in life. Your skin status later in life will influence how your general health is in later life. Thus, unhealthy skin can have effects on other body systems. The most prominent reminders of growing older are lines and wrinkles in the skin, thicker nails, and graying hair. These are caused by changes to the integumentary system, such as reduced thickness and vascularity of the dermis, flattening of the dermal epidermal junction, degeneration of elastic fibers, decreased rate of epidermal turnover, a reduction of melanocytes, and increased coarseness of collagen. With the older person's skin becoming so fragile, there are heightened risks of skin tearing, skin infections, pressure injury, and bruising. Not only are they at risk for injuries with aging, but also the appearance of the aging process potentially affects their body image, socialization, self-concept, and reactions from others. Next slide. All right, these are things to avoid when preventing and managing dermatological problems in the older person. It's important to avoid drying agents, rough clothing, skin irritants, highly starched linen, and also you don't want to bathe every day as an older person for fear of drying out the skin. Daily partial sponge baths are sufficient. Bathing every 3 or 4 days is recommended for the older adult. Also, you want to avoid the sun's ultraviolet rays that damage the skin. You should always wear sunscreen when you're out in the sun, when you're younger as well as in your later years. It's important because you won't know the damage the sun did until later in life. Depending on how easily your skin burns, it is recommended that you wear an SPF of 15 if you're fair-skinned and an SPF of 4 to 6 and a person who seldomly burns and tans a dark brown easily. It is also noted that even on overcast days, the sun's ultraviolet rays can penetrate the clouds, so it's always important to wear sunscreen. With that being said, there are ways to promote good skin nutrition and hydration. Those ways are being active, using bath oils and lotions, getting massages, and the early treatment of pruritus and/or lesions. By paying early attention to and handling the problem of pruritus or lesions, you are likely to prevent irritation, infection, and other problems. Next, Emily is going to take you through the ABCs of moles.
Alrighty, so we learned in first semester there's like an A, B, C, D, E, but for this class's purpose, there's just A, B, C, D. So we know A is asymmetry, B is border regularity, C is color, and D is diameter. So a mole is usually consistently brown throughout time. If it changes colors or variations in color are seen, it could be a sign of cancer. Specifically, melanoma may cause a mole to turn red, blue, or white. And then the diameter of a mole should be no larger than the size of a pencil eraser. So next slide.
Okay, so here are some nursing diagnoses related to dermatological problems. First, we have altered tissue perfusion, which is related to pressure sites and ulcers. Impaired skin integrity, which has to do with fragile skin or immobility. Body image disturbance, which is related to age-related changes to the skin, hair, and nails. Potential for injury due to more fragile skin. potential for infection due to ulcers. We have pain due to pruritus, infection, and ulcers. Anxiety related to altered body appearance and sexual dysfunction, related to altered self-perception due to age-related changes, or a more fragile vaginal epithelium. Next slide, please. So we're going to go over skin assessment. So the first thing is general observation. Much of the status of the integumentary system is evident to the naked eye. So a quick observation can assist in evaluating skin color, moisture and cleanliness, and the presence of lesions. Signs such as pallor or flushing can provide clues to health problems. Next, you have the interview. You want to ask the patient about any itching, burning, or other symptoms associated with skin problems. Then we'll have the physical examination. So you want to examine the entire skin surface from head to toe, including behind the ears, within skin folds, under the breast, and between the toes. Bathing and massages are good opportunities to inspect the skin in the course of patient care. You want to know any moles or skin tears, bruises, discoloration, and any other unusual findings. You also need to be aware that areas of pressure may be difficult to detect in dark-skinned persons. Skin turgor tends to be poor in most older adults. However, the areas over the sternum and the forehead do experience less of an age-related reduction in turgor and are good areas for turgor assessment. Okay, next slide.
Okay, so pruritus is the most common dermatological problem in older adults. And there are several things that can cause the skin to dry out. It can either be a disease process or a psychiatric problem. Like Melissa said earlier, excessive bathing can be a cause of it, and that older adults should only have a bath every 3 to 4 days. Disease processes that can cause it include diabetes, hyperthyroidism, uremia, liver disease, cancer, and anemia. Frequent skin assessments are necessary to check for skin breakage or infections so you can treat them faster, as well as ensure that there is not another cause, which could be like itching, scabies, lice. Bath oils and moisturizing lotions are helpful in treatment and prevention, but you want to make sure they're not super fragrant because that can actually cause it to dry out more. And zinc oxide and antihistamines can help with the itching. Next slide, please.
So keratosis, which is also referred to as actinic or solar keratoses, they are small, light-colored lesions. They're also usually gray or brown on the exposed areas of the skin. Keratin may be accumulated in these lesions, causing the formation of a cutaneous horn with a slightly reddened and swollen base. Close nursing observation is required because these lesions are precancerous. So removal of these consists of freezing agents and acids. They can be used to destroy the keratotic lesions. However, electrodesiccation or surgical excision ensures a more thorough removal. Next slide, please.
Okay. For seborrheic keratosis, they are dark wart-like projections on the skin. They can be located anywhere in the body. In the sebaceous areas, like the oily, sweaty areas, they can appear darker and shinier in color. And then or people that just have oily skin, they can have darker, shinier projections. And the drier areas or less oily areas are normally more light brown in color. Their size can range from the size of a pinhead to the size of a quarter, and they increase in size and number as you age. No, they normally do not have redness or swelling around the base. So on the bottom, you can see the pictures. The one on the left is like a non-sebaceous area where it's a lighter, drier look, and then the one on the right, darker, more shinier from the oil. Next slide, please. So for treatment and removal. So the small ones can sometimes be removed with abrasive gauze with oil, and you can just kind of scrub it off. The larger ones, like Stacy said, can be removed with freezing agents, curettage, and cauterization procedures. Seborrheic keratosis is a benign, but it should still be differentiated from other conditions to make sure it's not cancerous or malignant. And they can be really important to some individuals in relation to their body image. Next, please.
So there are 3 types of major skin cancer. So that's going to be your basal cell, your squamous cell, and your melanoma. Risk factors are going to be your age, exposure to the sun or UV, and therapeutic radiation. It's most commonly found in the face, but can be found throughout the body. And it can appear to be dome-shaped and covered by blood vessels, which is what this picture is. It's kind of hard to see on here, but it's like right in the middle. It's kind of where you see a little bit of those blood vessels popping out. And then prognosis depends on the depth of the skin cancer, not the type. So when they do take it out, they do have to make sure they get those edges because it's the depth, not the type. Basal cell is the most common and the least dangerous form because it usually does not metastasize. They can also have a pearly looking surface in addition to the blood vessel looking surface, and they can also be flesh colored, which is an example in the picture. So they don't necessarily have to be that black or red. Next slide, please.
The squamous cell carcinomas or cancers, as the name implies, squamous is going to be on the surface of the skin, or it could be on the lining of hollow organs and passages in the respiratory and digestive tracts. So wherever squamous cells are present, this can occur. The most prevalent risk factor for getting squamous cell carcinoma is through sun exposure. Less prevalent causes is exposure to hydrocarbons, arsenic, and radiation. They can develop scar tissue and can be associated with immune suppression. And they appear as firm, skin-colored or red nodules like you saw on Emily's last slide. Usually it stays on the epidermis, but it can metastasize, so it can spread. And the most common site of metastasis is on the lower lip. Next slide, please. Melanomas, again, as Emily said, is the most dangerous form of skin cancer. They tend to metastasize more than any other forms, and you really want to catch them early to prevent spread. The incidence of this is rising in the United States, probably due to sun exposure. Fair skinned individuals are the most prone to melanomas, and they're more prone than the general population. And there's a further increase of incidence as you age. So the older you get, the more risk you have of developing a melanoma. There are 3 classifications. There's the lentigo malignant melanoma, the superficial spreading melanoma, and the nodular melanoma. Next slide, please. So the lentigo malignant melanoma is a black, brown, white, or red pigmented flat lesion. It occurs predominantly on sun-exposed regions of the skin, so like your face and shoulders and areas. It enlarges and becomes more irregularly pigmented with time. So like we said earlier, once your moles or your projections start to change shape and have weird ridges and stuff like that, that's when you want to get them checked out. The mean diagnosis of a lentigo malignant melanoma is at 67 years old, according to our book. The superficial spreading melanoma is the most common type of melanoma. It has variable pigmentation of the plaque with irregular borders. It can occur anywhere on the body, and the incident rates peak in the middle-aged population, but the incident rates remain high up until the 8th decade. Next slide, please. The last type is the nodular melanoma. It can be found on any body surface. It is a darkly pigmented papule that increases in size over time. The treatments of melanomas, suspicious lesions should be biopsied for early detection. So once you notice a change in moles or anything like that, you need to have a biopsy checked. Usually when they'll excise them, and when they excise them, they'll do more than just the immediate area. They'll go a little bit further out just to make sure they get all of the cancer cells in case it metastasizes. And sometimes if you have enlarged palpable lymph nodes, they'll remove those too to make sure it's not spreading to your organs. Next slide, please. So these are some pictures. On the left, you see on the melanoma, and then next to that, you see a basal cell carcinoma, and then a squamous cell carcinoma, and then a keratosis on the right. Next slide.
So what is the most common dermatological problem in older adults? Anyone know?
Pruritus.
Yes.
Oops, sorry. Did you say pruritus? Is that what you, okay, all right. I was waiting for the answer to pop up, but I guess it doesn't.
Sorry, no, yeah, we haven't like the notes underneath, sorry.
Oh, no, that's okay. That's no problem. All right, so pruritus, that's a good
Yes.
question. It's a good question. I like that. All right. Next.
Okay, onto vascular lesions. So vascular lesions are caused by age-related changes that result in a weakening of walls of veins. They reduce the veins' ability to respond to increased pressure. Weakened vascular walls and this causes varicose veins. Poor venous return result in the edema of the lower extremities, and as a result of that, you get poor tissue nutrition. The legs gain a pigmented, cracked, and exudative appearance, like you see on the right. The main risk factors are obesity and heredity. Next slide. So vascular lesions can result in stasis dermatitis, which is an inflammatory condition associated with chronic venous insufficiency. Scratching, irritation, and other trauma can be caused by tight elastic band stockings that are sometimes used to treat the swelling. Leg ulcers or stasis ulcers can form from the stasis dermatitis. Stasis ulcers often appear on medial aspects of the tibia above the malleolus, so just above your medial ankle bone. Prior skin breakdown, there will be dark discoloration of the skin. So before you start to see the ulcer form, you'll start to see discoloration first. Stasis ulcers need special attention to facilitate healing. So you really need to prevent and control infection for stasis ulcers, remove the necrotic tissue, so you need debridement. Diet high in protein and vitamins are recommended to promote healing, and once healing has occurred, you have to make sure it doesn't come back by taking preventive measures. Next slide, please. Treatment for vascular lesions is diet and planning for weight reduction. As we said, one of the most common risk factors is obesity. You want to promote venous return by elevating legs several times a day. So you can elevate the legs and kind of use gravity to help you out. You want to avoid standing for long periods of time, sitting with your legs crossed, or wearing garters. Elastic support stockings may be prescribed, but the older adult population might have issues putting on the elastic stockings. And you also want to watch out for those ulcers that can form around the band of the stockings if the swelling becomes too much and they get too tight. Ligation and stripping of affected veins to prevent further episodes of status dermatitis can also be used. Next slide.
So as we've seen in our clinicals, pressure injuries are unfortunately a very common occurrence. It's something that nurses should take very seriously because most of the time they are avoidable and they can be very painful for the patient. A pressure injury, they were recently called pressure ulcers. They're a result of tissue anoxia and ischemia from pressure. Overall, this can result in necrosis, sloughing, and ulceration of the tissue. The most common sites are the sacrum, the greater trochanter, and the ischial tuberosities. They can also include other multiple sites such as the frontal bone, the sternum, the mandible, shoulder, ribs, patella, a lot of places where there's bony prominences. The sacral pressure injuries are usually a result of an individual remaining in the supine position for longer than their pressure tolerance. The greater trochanter, a result of a side-lying position, and ischial tuberosities are from an individual staying in a wheelchair or a chair too long. Older adults are at a high risk for pressure injuries due to multiple factors. This can be due to fragile skin that damages easily, a poor nutritional state, reduced sensation of pressure and pain, more frequently affected by immobile and edematous conditions, which contribute to skin breakdown, and they take longer to heal than most younger people. And due to these factors, the most important nursing measure to prevent the formation is to encourage activity, also turn the patient who cannot move independently. The patient's individual pressure tolerance determines the frequency. I know that in our first quarter, we were told every 2 hours, but that may not be sufficient for every patient. We can also use pillows, flotation pads, alternating pressure mattresses, and water beds to take pressure off of bony prominences. Lamb's wool and heel protectors are also useful in preventing irritation. We should be massaging the bony prominences as well to promote circulation, and it will help keep the tissue well nourished. In addition, patients mainly in wheelchairs should be assisted with shifting their weight at certain intervals. The nurse should make sure that the patient's sheets are wrinkle-free, and we should check the bed often for foreign objects such as utensils, syringes, pen caps. Sensitivity should also be used for diagnostic or therapeutic purposes because they can apply pressure and injure the skin. This can include braces and blood pressure cuffs. We should keep that in mind also as we're doing our vitals. We should also prevent shearing forces. Instead of sliding the patient up in the bed, we should be lifting them, and they should not be elevated more than 30 degrees. A person who is incontinent should be thoroughly cleansed with soap and water and dried after each episode to prevent skin breakdown. And lastly, they should be having a high protein, vitamin-rich diet, which is going to help with the issue of a poor nutritional state. Next slide, please. So the stages of pressure injury, this staging system describes the recommended method for describing the stages of injuries. It's using the minimum data set tool for assessing for nursing home residences. So to start off, we have our deep tissue injuries. This is a purple or maroon area of intact skin or a blood-filled blister due to damage of underlying tissue. This area can be painful, firm or mushy, and warm or cool. It can progress quickly, so we need to act as soon as we see it and expose additional layers of tissue. So stage 1 is a persistent area of skin redness. It can be with or without a break in the skin, without a break in the skin, and it does not disappear when the pressure is relieved. It's usually found over bony prominences. Stage 2 is a partial thickness loss of the skin involving the epidermis that presents as an open, ruptured, or open, shallow crater. Stage 3 is a full thickness of the skin that's lost, extending through the epidermis and exposing the subcutaneous tissue. It presents as a deep crater with or without tunneling. Stage 4 is a full thickness of skin and subcutaneous tissue that is lost. It can expose the muscle, bone, or both. This also presents as a deep crater that may include necrotic tissue, slough, or eschar. Tunneling and undermining is often present. And an unstageable pressure injury, this is where the full thickness of the tissue is lost and the base is covered with slough or eschar. It cannot be determined until the slough or eschar is removed to expose the base and assess the actual depth of the wound. And lastly, the deep tissue pressure injury. It's a localized area of non-blanchable deep red or purple discoloration with a red or a dark wound bed or blood-filled blister due to intense or prolonged pressure or shearing force. And this skin may be intact or not intact. And if you want to see visual examples of the different stages, they're located on Bach 27.1 on page 397. I unfortunately couldn't fit all of them in here, but they're in our book there. Next slide, please. So our treatment, the treatment depends on the stage of the injury and as well as the identified fault and signs that I'm about to go over. So it depends on hyperemia. This can be treated by relieving the pressure by the use of a square adhesive foam. It is recommended that we use the products such as Duoderm or Tegasorb before applying the adhesive. For ischemia, ischemia may cause the epidermis to blister, so the skin should be protected with Vigilon, which contains water and is soothing to the area. Although if the skin is broken, it should be cleansed daily with normal saline or a product suggested by the facility's policies. With necrosis, this type of sore requires a transparent dressing that protects it from bacteria but is permeable to oxygen and water vapor. If it is bad enough, sometimes antibiotics have to be used also. And with our deep tissue damage, eschar is frequently present and it cannot heal until it is removed, so debridement is essential. Next slide, please. All right, question. Select all that apply, everyone's favorite. Why are older adults at high risk for pressure injuries? Select all that apply. A, often are in a poor nutritional state. B, have skin that is fragile and damages easily. C, move around too much while in bed. D, have less bony promises than younger adults. E, are more frequently affected by immobile and edematous conditions. Who wants to take a shot at it?
A, B, and E.
Yes, that is correct. And again, sorry, it's in the notes. We didn't get a chance to actually have a
So would you say that again so everybody gets the answers? What was your answers again so everybody hears it?
A, B, and E.
Okay, A, B, and E. Okay, good.
Yes, that is
That's
correct.
a great question. That's a good question.
Yeah. Got one more after this too.
All right.
All right. Which of the following methods is essential in preventing skin breakdown? A, avoiding the use of lotions and oils. B, vigorously rubbing the patient dry. C, massage of bony prominences. Or D, a low protein, high carbohydrate diet.
Mm-hmm.
Anyone?
B.
Not B.
And I guess a D.
Also not D.
A.
Not A. Last one. So the answer is C, because we want to massage the bony prominences to promote circulation.
Oh, I'm sorry.
I
was misunderstanding the question.
Oh, okay. Yeah, so we want to use lotions and oils because it helps keep the skin hydrated, and we don't want to vigorously rub the patient dry. We want to dab them dry, and we want the patient to have a high protein, high vitamin diet.
So, Anne-Marie, why would you not want to vigorously rub the patient dry?
That can go over their pressure tolerance too. It can cause also little cuts on them, and it can also over dry the skin. You just want to dab it very gently because they have thinner skin also. Yes,
it's the thin skin that would really be detrimental for those patients if we rubbed it really vigorously, like you know, we would do it now because our skin is in decent shape, but our older patients, I'm sure you've seen lots of those. Now, C probably threw some students off because it says massage of bony prominences. What is the difference between a bony prominence, just like a normal skin color, and one that is red? What is the difference of care? There's a big difference in the care of those. And why?
Is it because with the massaging, you're promoting circulation, and then if you feel redness, it's possibly they're not being moved or they're not being turned?
That's, yes. If they're not being moved and turned and that redness stays there, then the more that we rub that redness, it's going to cause more damage to the underlying skin tissue. So if it's already reddened, we don't want to rub that until that red goes away. Okay, because that's an inflamed area. And the more that we rub it, the more it could cause damage. So it didn't indicate here that they were red. It just says massage of the bony prominences. Well, obviously that's perfectly fine to get the skin and circulation like the teams mentioned. But I think that's important to note the difference between massaging a red bony prominence and one that is not red. Okay, good question. Mm-hmm.
And next slide, yes, thanks.
Yes.
So there are a few alternative therapies that will work just to help with healthy skin. So aloe can be used externally to treat minor cuts and burns. You never want to use it internally for them. Chamomile can be used externally for skin inflammation. Witch hazel can be used for bruises and swelling due to its astringent effects. Thyme oil is an antiseptic. Thyme and rosewood oil can be used for acne. Rosemary oil can also be used for cell regeneration. Basil, cinnamon, garlic, lavender, lemon, and sage can be used for insect bites and stings. Biofeedback, guided imagery, and relaxation exercises can help with stress and treat skin eruptions and other symptoms associated with dermatological disorders. Zinc, magnesium, essential fatty acids, and vitamins A, B, and E can be beneficial for skin disorders. And then next slide, please. Which alternative therapy is best used for minor cuts and burns?
C.
Aloe.
Yeah. Yep, C. That's right.
Does anybody have any aloe plants in the yard, the backyard? Because you can have these at home and just trim it. Okay. Or a lot of people do actually have, they grow those actually. Yeah. All right.
Which areas are used to assess skin texture in the older adults? Select all that apply.
What do you think, class?
Forehead.
I hear forehead. Go ahead, Anne-Marie. Stacy, this is your question.
Okay, yeah, so that's one. There's one more answer. If anybody wants to give it a shot.
Sternum.
Yeah, so the sternum and the forehead, that's correct.
Good. Absolutely.
Next, oh, okay. So I did the case study at John Knox. She was an 85-year-old female. Her admitting diagnosis was cognitive disorder, and she just was unable to take care of herself from that point. She has a history of paraplegia. Her assessment was bedridden. The patient was bedridden upon arrival. Patient was cognitively impaired and showed signs of dementia, and she had a stage 4 pressure injury. So due to being paraplegic and bedbound, the patient suffers from a stage 4 pressure injury to her sacrum. I was able to help the LPN do the dressing change of her wound vac. The LPN talked about how she had had this pressure injury for a couple of months now, and the tissue was just now starting to grow back. So it had been like a good 3 or 4 months that this lady had had this pressure injury. It can take anywhere between 4 months and 2 years for a stage 4 injury to heal. To help with the healing, the patient was on a high protein and vitamin-rich diet to promote tissue health. She was given Boost enhancement shakes with meals to help with this. So when we changed the vac, there wasn't much blood coming from it, and we were able to get a good look at the wound as we had her turned in order to change the dressing. The only thing that I could see was like risk of infection. When we did change the dressing, the smell was, I've seen pressure injuries before, and I've never smelled anything like this. But yet she wasn't on any antibiotics, so I was kind of like questioning that because she wasn't on anything. They just kept changing her wound vac every couple days. So that was And the lady couldn't tell me why she wasn't on any antibiotics. But I got to see the stage 4 injury. It was interesting. Do you have any questions for us?
So how deep was this wound?
Oh, it was to her bone.
So you,
I saw everything.
ooh.
Yeah.
So when you class, when you see a wound that's deep, even with a wound vac, what are some complications that you can perhaps anticipate could be something that could occur with this patient? What are some complications if somebody gets a stage 4 wound to the bone?
Osteomyelitis.
Oh, yes, yes. Tell us about osteomyelitis.
It's an infection of the bone.
Okay.
It's very painful.
Yes, it is very, very painful, absolutely. And it's very difficult to treat. And the thing remember with osteomyelitis, you probably studied this, is that when someone does get it, and they feel like they're healed up, it could come back 4, 5, 6 years later because it's hiding in the bone. And that patient could come back with another outbreak of osteomyelitis of that particular bacteria. Yeah.
So with this lady, she had a cognitive disorder. She couldn't speak clearly. She was trying to ask us questions, but we could not understand her. And she was paralyzed from the waist down. She did her feet would twitch, but it was just a reflex of some sort. I tried to bend her legs, and the LPN was like, "Oh no, her legs don't bend." And I'm like, oh, okay, why don't they bend? So they were they had contractures, but they were totally straight. So, I mean, she couldn't even tell us if she was in pain, and she didn't feel any pain either, because I was like, shouldn't we be? Because I wasn't aware that she was paralyzed before we went in there. And I was like, well, shouldn't we be putting something on, so that we can change dressing? And she's like, oh no, she doesn't feel it. So
how do we know that she didn't feel it?
Well, I mean, she didn't make faces, she didn't scream, she didn't grimace, she didn't do anything.
Okay.
So yeah, I mean, she definitely did not feel it.
Okay.
So.
Was she at home when she developed this stage 4, or was she in the nursing facility?
She was in the nursing home.
Really?
Yeah, she had been there for a while.
Okay.
Yeah.
Do you know that most pressure injuries are preventable?
Yes.
Yeah.
Yeah.
Right. That's pretty deep, a stage 4 in the facility. That's really kind of scary. Although we do know that no matter what kind of turning schedule, sometimes patients just develop these pressure injuries, but that's not the norm.
Yeah. Well, I did do a little bit of research because I was like, geez, how, because they couldn't really tell me how long it took her to get it. But when I did research, it said that you can get one between 1 and 2 hours. It just depends.
You can develop pressure injury stage 1 within a couple of hours or less.
Yeah.
But then if it's not managed, if the patient is not turned and a thorough skin assessment is not completed, then that could be for a long time. Nobody would notice it or even report it. Was she also in a wheelchair? Was she able to get into a wheelchair?
I did not see her get out of that bed the whole time, the whole day I was there.
Okay, well, her legs don't bend. That's another thing. Have they always been in that position?
Yeah, I mean, she did have a pillow on her left side to take a little bit of the pressure off, but I mean, obviously the damage had already been done.
Right.
So they were just trying to prevent no more being done to her.
So what kind of nursing interventions class could you have provided for this woman before she ever developed a stage 4 or her stiffening of her legs? Being paralyzed doesn't mean that her legs initially could not be turned. So she developed contractures over time. So if we could go back in time, what kind of nursing interventions would you want to do for her?
I would have
Passive
done
range of
passive
motion.
range of motion exercises with her.
Yes, lots of that. It would have to be very, I would say aggressive, not hurting her, but when I mean aggressive, that means daily. I mean, every so many hours we'd go in there and do that type of activity to help prevent some of those contractures, because it doesn't take long for contractures to form when the patient is not using those muscles. So she may not be getting up because she can't get her legs down, but they do make wheelchairs or chairs, they have those big chairs that have wheels on them and their legs can go out, so getting up. However, how do you think that would impact her wound on her sacrum?
I would just make it worse because she's sitting up so far.
Yeah, at this point that would be. So if she had been earlier in her earlier days, if she had been in a wheelchair, perhaps doing some additional movement in the wheelchair. So about every 15 minutes, this person would have to be moved a little bit to try to prevent some of this damage. Although we do know from research that sometimes pressure injuries will occur regardless of how much work that the nurse or the physical therapy team will do. So there is a good thing. All right, so she wasn't alert at all?
No, she would mumble a little bit.
Did she look like she knew that she was awake? I mean,
yeah, she knew she was awake. Actually, Uma and Alexis were the three of us got to be in there. We got to learn about wound vacs that day, and she was coherent a little bit. When Uma said her name, the woman thought that she was Omar. Her name was Omar.
Oh.
So yeah, so she was in and out.
Okay.
So because she would just start like gibbering, But then sometimes like she thought Uma was Omar, and with the short hair, we got called boys a lot on the unit because our hair was back,
Right.
So
yeah, that does happen from time to time. Yes.
Yeah.
Okay. All right, that's a very, very interesting case, and hopefully, yes, she will not have any further problems with that. But the smell of that is, they do have an unusual odor, but did you feel that it smelled like infection? There's a difference between the smell of body juices.
So I went the semester of our public health, I went to the wound center there, and I got to see a stage 4 pressure injury on another man who was paraplegic, and his was, down to the muscle. I saw like the doctor stuck his fist in this guy's leg, and it was amazing, and it did not smell. It was the cleanest wound I'd ever seen. So that's the only thing I've ever experienced. And so then we got to see this wound, and it was, I could smell it from 5 feet away.
That's kind of unusual, I'll be honest with you.
Yeah, the LPN was even like, if the smell bothers you, you can leave. So it was vastly different from the stage 4 that I saw in the wound care center,
What kind of exudate did you see? What was the color of it? What was the...
See, that's the thing. It wasn't, because when she changed the tubing, there was barely any blood. It was like, there wasn't, it was red a little bit. It was red, but there wasn't a lot of it.
Okay.
There was not a lot of it in the wound vac at all. So it wasn't really putting out anything anymore, but it's just the round, like the edges, where it kind of was starting to like try to come in.
Mm-hmm.
It smelled really bad.
Wow. Okay. Well, the only way to determine if that was infected would have been some type of wound culture.
Mm-hmm.
Yeah. Did she have a fever Did you have any unusual vital signs?
No,
All right.
no,
Okay.
not at all.
Well, very fascinating. That was really fascinating.
Thank you.
And you will see a lot of patients out there with all kinds of wounds and that need skin care. All right. Okay, there's your references. Is there anything else? Nope, that's it. Okay, thank you for this presentation. A couple of comments I would like to have, and then let's see if maybe your classmates would have some comments as well. You talked about the UV, to taking care of your skin and that. What do you think of tanning beds? Is there a problem with tanning beds and skin?
Yes.
Oh, yes.
Okay. So, but we still have a lot of tanning beds out there, right? Yeah. So again, taking care of the skin definitely needs to be a primary consideration for anyone using a tanning bed. Yeah, because I know they protect their eyes, but skin can be damaged from that. All right. Has anybody ever seen what we call a stasis ulcer on your patients? Actually seen one?
Yeah, at the wound care center.
Yeah, can you describe that to us and what it looked like?
I mean, usually their legs are very edematous and they're just the legs are just weeping, like fluid drainage. Yeah, discoloration. They're like purple, like blue, purple.
A lot of brown colored skin as well around those wounds. Yeah, kind of brownish. Did you notice an unusual smell from the weeping of the skin?
It was a really good day at the wound care center. I didn't smell anything, thank God.
Yeah, because a lot of times, if you will have a patient that has weeping of the skin, it'll smell kind of oily and like a rancid, oily smell. And so that's clearly an indication that there's some kind of lymphedema going on. And so all of that is coming out onto the skin. And it can have a kind of really strange, oily, like it's old grease smell. So keeping those legs clean are very, very important. And stasis injuries or stasis ulcers take a long time to heal. It takes a long time to heal. And when I was working in home health, there was a number of patients that were at home, but they would have a home health nurse come out a couple times a week and change their dressings on those lower extremities. So it was really, it was quite an eye-opener. If you've ever seen one, then you'll understand how devastating those can be as well. All right, so good. Let's see, a couple more things. Well, you mentioned the vascular lesions, but I'm wondering, remember you talked about standing on your feet for long periods of time can increase the varicosities and things. How is that in relationship to nursing practice? To you as a nurse?
I think standing could be a risk factor, but at the same time, we're walking and moving a lot, so our muscles are pumping that blood.
True. We do find that nurses do develop varicosities even though they're moving all the time because they're on their feet for hours and hours and hours. And so many of them, as they get older, they do develop some type of varicosities and also some dependent edema because of that. So the reason I bring that up is that you're brand new nurses and you're going to be out there working, so take care of your legs. Remember the use of those short compression hose. While they're good, over time, that can actually cause like a rubber band effect around the calf area. So again, that could affect the venous blood flow as well. So just take good care of your legs. Keep them propped up as much as you can. There's not a lot of time. I know in nursing we never sat down, but just think about it, because you're going to have 20, 30, maybe even 40 years of nursing practice out there, you know, walking around on those floors. So take care of yourself. I just wanted to just remind you of that. And the last thing I had, let's see. Oh, is there anybody in here who would be interested in doing dermatology nursing? Anybody interested in looking at all these things like the keratoses and all of those?
Yes.
Okay, Uma, you know, that's definitely a specialty. Nurse practitioners can specialize in dermatitis and dermatology. But one of the things you'll find, as you have probably already recognized studying it, there is so many different lesions and skin problems and skin things that it takes a lot of education and understanding of to distinguish one little teeny spot from another. So if you like that, that's definitely something that it's definitely a need, dermatological nursing for sure, right? And there's all kinds of ways to get to that point. Working in a dermatology office, getting a master's degree, of course, there's lots of different ways to reach that. And we don't have enough nurses that really do specialize in dermatology, because many of us specialize in all the med-surg stuff, you know, the cardiac and the lungs, but there's not a whole lot of nurses that go out there and specialize in all the wound stuff or all the things that are on the skin. So, all right. So does anybody else have any comments or anything on this presentation? It was very clear. It was concise. And you pointed out all the most important pieces in this little chapter. Any other comments? Okay, if there's no comments, let me see if somebody's got something in the chat. Okay. Okay. Steve, did you get into class? Kayla, were y'all able to get in? I'm just seeing a.
Yes, thank you.
Okay, sure. I'm sorry, I didn't see that until just now because I don't really read the comments until after we stop talking. All right, so that's good. All right, so it's 10:02. Let's come back at 10:15, and we will start back into talking about the depression scale and some of our mental health disorders. It's a fairly short chapter and won't take us long. Okay, I'll see you back here at 10:15.